Okay, well, hello everyone and welcome to Lifespan Physiology. For those of you who haven't met me before, my name is Alison and I'll be the course coordinator and doing the majority of lectures and tutorials for this topic. I've got a couple of lecture topics that we're going to be talking through today. The first of these is preconception, and then we'll be moving on to talk a little bit more around that post-conception phase, pregnancy, in particular changes in maternal physiology. So to start with preconception here, we're going to be talking about some key components in hormone regulation of male and female reproductive physiology, and then also considering nutrition-related factors that may influence fertility in men and women, with a particular focus on regulatory aspects of weight, in particular body fat levels, and some specific nutrients. Okay, so talking about the female reproductive system, so I'm anticipating that some of this is going to be familiar to you already, but it causes no surprise that the ability to conceive requires a really healthy reproductive system, along with an adequate and balanced hormones that are relative to that male and female physiology. So key female organs include the ovaries, fallopian tubes, uterus, cervix, and vagina. And you can notice that all of these reproductive organs are contained internally or within the body. That's a little bit distinct to that of the male reproductive organs, which we'll touch on in a second. So reproductive physiology really begins in the first months after conception. So even as that female fetus begins to develop, you have approximately 7 million immature ova or eggs that are formed during that period of time. But over the course of development, we have a continuing loss of those eggs, such that only about 500,000 remain by the onset of puberty and very few by menopause. Menopause obviously is marked by some hormonal changes where we have a reduction in levels of estrogen and progesterone, such that women stop menstruating. Now, hormonal changes trigger thin maturation during puberty, and this is marked by the onset of the monthly menstrual cycle. And this is regulated by hormones to specifically control the release and maturation of eggs, ovum, and also to control the accumulation of blood and nutrients in the uterine wall. Obviously, that's really important because if pregnancy is to occur, then that's how that egg will be, or that implant will be nourished. Comparatively, in males, we have organs that are located outside of the body, such as the penis and testes, and then a number of others that are located internally, including the epididymis, the vas deferens, vesicles, the prostate gland, and then the urethra. Similar to females, reproductive physiological developments begin in the first months after conception. All infants are born with sperm-producing capabilities, but actual sperm production doesn't begin until puberty, and then you see a gradual decline over time, particularly marked by around 35 years of age, where you have a decrease in the number of sperm that are produced, and then also the viability of those sperm. But in comparison to females, males continue to produce sperm up until death. However, the quality of those sperm that are produced can differ over time, or starts to reduce over time. Now, not surprisingly, those reproductive capabilities are really established during puberty, where we have those significant increases in testosterone and other hormones that are involved in reproductive function in males. So this table here presents the key fertility hormones that are involved in reproduction. So it all begins primarily with the hypothalamus, which is an area within the brain that is responsible for the regulation of a number of different biological functions, including reproduction. So the hypothalamus produces gonadotropin-releasing hormone, GnRH, which stimulates the pituitary to produce the hormones FSH, follicle-stimulating hormone, and luteinizing hormone. So these hormones are really important because those FSH and LH are, in females, they really regulate the menstrual cycle. They're involved in the development of follicles, which are sacs which contain eggs, and then levels of FSH then stimulate those eggs to be released. So as we go through, we also have luteinizing hormone, which is responsible for the production of testosterone in males. And similar to FSH, those hormonal productions are really important because they really regulate those sex-specific hormones such as estrogen and progesterone, which are important for the release and development of the egg, as well as the uterine wall development during the menstrual cycle. Within males, testosterone and progesterone are also important. So they are important for the maturation of sex organs, the production and release of sperm, and then also the formation of muscle tissue and other functions within them. So the ability to conceive requires a healthy reproductive system. So we need to have this adequate and balanced hormones within men and women. The really important components are that we really need healthy eggs. So in females, we have to have that ability to release eggs. We need to be able to facilitate fertilisation of those eggs and nourish the implant at the time that it is fertilised. Within male, it's not just about the production of sperm, it's about how many of these sperm that we produce, as well as the shape of these sperm so that they are sufficiently formed and they can actually move as they're required. Now, the production and the quality of sperm will decline over time in men. So when we're talking about the role of nutrition, typically we're thinking about how does key elements of nutrition, those can be related to energy and also which influences body fat levels, and then also specific foods and supplements. So these particular nutrition-related elements can affect fertility by changing the environment where sperm and eggs develop, and then also changing hormone levels. So in particular, those ones that are released by the hypothalamus and the pituitary gland, but then also sex-specific production of estrogen, progesterone, and testosterone. So we're going to talk through a little bit more of those. So you can see here in this table here, I've highlighted some of those that are associated with energy or weight related. We'll talk through those first, and then we'll talk about some key nutrient related elements that can influence fertility. Now you can see there's a bunch of other ones that are related to physiological development or diseases and so forth. We're not going to be focusing on those, we're just going to be sticking to those that are nutrition related. Okay, so the first concept to think about is that body fat is not a an immune cell or a benign cell. It really is a product that produces estrogen, testosterone, and a hormone called leptin. And this has, as you can imagine, significant impacts. If we think back to the fact that estrogen and testosterone are regulators of physiological development, the release of and regulation of eggs and so forth, then that's going to be a factor to consider. So we need to make sure that you understand that body fat is this producer of these particular hormones. And these can therefore interfere with follicular development. So a reminder there that follicles are sort of immature eggs, and they release eggs when they mature. And it can influence with ovulation, so the timing of and the release of those eggs, and then sperm maturation and production. So body weight is really important at both the high levels and also the low levels. So individuals who have inadequate or low body fat, it pushes that body to respond in a preservation mode. So instead of being in a system of reproductive, it's in about preserving that individual at time. And this influence of low body weight or low levels of body fat on preservation mode is illustrated by a number of historic events. So there's times during historic events where there's been significant food shortages, sort of during famines, or whether that be deliberate during war-torn countries where they've stopped food being delivered to certain areas of countries, and those food shortages have led to really dramatic declines in birth rates because women have become less fertile. Their body has been forced into a preservation mode as opposed to a reproduction mode. So in women, low levels of body fat have been linked to delayed onset of menstruation in adolescence. Classic examples of this would be gymnasts. So gymnasts who are often quite petite, very low, lean, small individuals. There's a lot of evidence showing that they have later onset of menstruation than a normal population would. There is evidence to suggest that a BMI within a certain range, so above 20, is needed to sustain reproductive functions. So when we talk about people being underweight and linked with body composition, it's because we need a certain level of body fat to maintain the production of estrogen and testosterone so that we can continue that regulation of physiological function. So these low body fat due to low levels of estrogen is linked to irregular or absent menstrual cycles and therefore ovulation in women. And the whole concept of this is that we really want to, the body is trying to prevent pregnancy in women who are unprepared for the energy and nutrient cost of it. So it's about preserving the female body, but then also making sure that they're not getting pregnant when they can't maintain that pregnancy. In men, low levels of body fat are linked to reduced sex drive, so lowered libido, and then also reduced sperm production in men because of low levels of testosterone. So in addition to this, there's that underlying low levels of body weight, but it's also apparent that in people who are of normal weight, if they lose more than 10 to 15% of that body weight, then that is associated with an imbalance in hormone concentrations as well. So this is not people who are overweight or obese losing weight. This is people who are a healthy weight and then they go on and lose weight. And so again, this is associated with changes to those hormone levels, which influence menstruation, ovulation, and sperm viability and motility. Interestingly, in men who are normal weight and lose more than 25%, more than a quarter of their body weight, then sperm production is reduced or ceases. And these processes will return when body weight is returned to normal. So I'll talk a little bit more around those people who have excess body fat, and this is probably one of those concerns that we have more prevalence of in Australia, given our levels of overweight and obesity. So excess body fat typically is, tends to be most apparent when people reach a BMI of above 30 kilograms. So that's moving into that obese classification. And there's a term there where people are considered to be subfertile. So they're not infertile, where they cannot have children, but they're subfertile, so that they're not as, compared to normal healthy weight women and men, they're less likely to be fertile. So in women, this is linked to the fact that high body fat will increase the production of estrogen, androgens, which are the male sex hormones, as well as leptin. And these higher levels above what is considered to be usual contributes to menstrual cycle irregularity, ovulatory failure, so they don't release an egg when they're expected to, and then also the egg doesn't develop properly. In men, high levels of body fat is associated with lower levels of testosterone, but then higher levels of estrogen, which is that female reproductive hormone, and higher levels of leptin. This leads to reduced sperm production and also erectile dysfunction. The other thing to remember, so leptin is essentially, it is considered to be a bit of an inflammatory cytokine, I guess, an inflammatory molecule, and that means that it can be associated with increased oxidative stress because it is inflammatory. Fat cells in themselves also produce other inflammatory cytokines, other inflammatory molecules that contribute to stress and chronic inflammation within the body. So individuals who have high levels of body fat, they have these impaired hormones that are associated with their specific sex. So whether that be too high levels of estrogen in men, or too high levels of testosterone in women. And then they're also in this state of chronic inflammation due to the amount of fat tissue that they have. This can lead to oxidative stress. And this means that oxidative stress is responsible for doing things like damaging the membrane of sperm. It might damage the DNA within that sperm. So you can see that it's that particular sex cell is really ineffective. It can impair egg and follicular development and interfere with the implantation of the egg in the uterus. So it's really important that we can try and manage this stress, this oxidative stress, and reduce this inflammation. And obviously reducing body weight is appropriate for that. So weight loss is really important in people who are overweight or obese if they're thinking about conception and trying to improve their chances of having children. And this is because it can improve the regulation of hormones and also reduce that chronic inflammation. So they've done, a few studies. I've just pulled one systematic review here that has looked at women who have undergone weight loss, and they've achieved quite significant weight loss due to having had bariatric surgery, which is surgery that reduces they haven't specified here, but it's essentially surgery that reduces the size of your stomach, so you can't eat as much, and so therefore you lose weight. And these people here have then said, well, how successful were these people at having a pregnancy or becoming pregnant once they had this surgery and achieved this weight loss? And they looked at the event rate, so this is sort of the frequency, and they've reported so in the range of about 22% to up to 92% success in becoming pregnant. So on average, it's it is really important that people achieve a healthy weight to try and become pregnant. So we do have some recommendations on this. So essentially, the recommendations is that we want women to try and achieve a healthy body weight prior to becoming pregnant. We don't want them to lose weight during pregnancy. That's really going to be a problem for the baby. But we want them to achieve a healthy weight before they become pregnant. So women are advised to either lose or gain weight before becoming pregnant. So we've talked about some of those weight-related ones. We're now going to talk a few more about the nutrient-related elements. So there's a few nutrients that are specific for men, and there's a few nutrients that are specific for women, and then there's some that cross over between both of them. So they have identified that antioxidants are really important to have within a typical healthy diet, and this links back to the fact that antioxidants are important for preventing oxidative damage. Okay, so they reduce the presence of reactive oxygen molecules that can damage polyunsaturated fatty acids in cell membranes, and therefore that maintaining or reducing oxidative stress is really important. You can see here there's ways in which that oxidative stress can damage cells and eggs. In men, zinc has been identified as being important because it has a role in oxidative stress as well as in sperm maturation and testosterone synthesis. So they've linked low levels of zinc with poorer sperm quality, concentration, and an abnormal shape. Alcohol has been linked to a reduced ability to conceive as little as 1 drink per day, so more than 1 drink per day. And this is both in men and women. It's thought that it's related to hormonal changes. So in women, it can increase estrogen, which therefore influences the production of FSH and linked to low or reduced ovulation. In men, it can increase testosterone above typical levels, and that's associated with quality of sperm. Heavy metal exposure is particularly impactful in men. They've had a number of studies that have linked particularly cadmium as being quite a toxic heavy metal, as well as lead, other heavy metals such as copper, nickel, manganese. And the relationship with this is because these heavy metals can bind to receptors which block the action of those hormones. So therefore they have changes again to sperm production, shape, motility. Iron deficiency is really problematic in women. So low iron is related to infertility because it's linked with lack of ovulation. So women who are iron deficient don't release eggs. Low iron is related to infertility because it's linked with iron deficiency before conception. So women who are deficient in iron who become pregnant means that it increases the risk of iron deficiency anemia in pregnancy. We'll talk a little bit more about this later on. And it increases the potential for babies to be born with low iron levels. And low iron in infants has been linked to poor growth and motor development. So we really want to get on top of that before the woman becomes pregnant. It's also linked in early pregnancy, in later pregnancy to increased rates of preterm delivery, which means that the baby comes early and isn't fully developed. And we also know that because iron requirements increase in pregnancy, it's really hard to meet those needs. And so we want to get on top of their iron levels before they become pregnant, so they're at a normal level, so that we can try and maintain those normal levels during pregnancy, as opposed to try and, doubling or tripling intake during pregnancy to try and meet those needs when they start at a really low level. It's really difficult to do. So encompassing all of that, we need to think about how men and women, to some extent, what's their diet and lifestyle like. We need to focus on an adequate and balanced diet with particular nutrients there to make sure that we're physically active and avoid those unnecessary lifestyle behaviours, alcohol, smoking, drug use. There are some specific recommendations in the preconception phase associated with avoiding vitamin A, really high levels, particularly those in supplements, because they can be teratogenic, which means that they can cause birth miscarriage and then also developmental issues with the baby. And so high levels of vitamin A should be avoided. And there are specific recommendations about commencing folate supplementation during the preconception period and iodine supplements. So we'll talk a little bit more about those two later ones that are listed there, folate and iodine, because they're so critical. So folate is really important for cell division. It's a really, it's a fundamental preconception nutrient. And the problem with, and the reason for this is that because folate is critical really, really early in pregnancy. So the neural tube, and that's what it's responsible for with the baby, starts to begin at about 17 days after fertilisation. So that's not even 3 weeks after the woman may have become pregnant. So often a female doesn't even know that they're pregnant, and if they're unaware of that and their nutrient level or their folate levels are low, then they may not have the proper ability to nourish that baby, and it can lead to neural tube defects. So that's why the supplementation recommendations are that if you're planning pregnancy, you should start at least, go back to this slide here, so at least 1 month before and continue for 3 months during your early phase of pregnancy to make sure that you've got the folate needed to provide the nutrient that's needed for cell division, because it happens so early in pregnancy, okay? The other one is iodine. So iodine supplements are also critical, particularly in those early phases. And prior to conception in the female, they have a role in keeping normal, regulating ovulation, metabolism, and weight management. So you can see that optimal levels of iodine is important for the female who's becoming pregnant. But then also during fetal development, they're involved in brain development. And again, that occurs really early in pregnancy as well. So we need to make sure that supplementation occurs and there's sufficient levels of and iodine. We're going to talk about these two nutrients in more detail as we go through the pregnancy phases, but suffice to say that recommendations for supplementation are really critical in preconception phases. Okay, so that ends the section on preconception nutrients. Does anyone have any questions about that at this stage? Pregnancy. Okay, so once the woman becomes pregnant, we need to think about those physiological changes that happen through this content here. Okay, so this is that kind of preconception and pregnancy timeline. So to poor growth and motor development, we really want to get on preterm delivery, which means iron deficiency is really problematic in women. So low iron is related to hormone that maintaining or pregnant, and if they're unaware, is then going to be really important. Blood. Okay, we need to make sure that the so you've got to go that I guess nourish is associated considered to think about woman becomes pregnant. We need to think about those physiological changes that happen, because any of the physiological changes that occur need to be supported by nutrition. Okay, so we're going to talk through some of those key changes in maternal physiology. All right, so there's some learning outcomes here that you can have a think about, but they'll be pretty evident as we go through this content here. Okay, so this is that kind of preconception and pregnancy timeline. So the key things to think about here is that when we're talking about a full-term pregnancy, it's considered to be 40 weeks. So you can see from 0 to 40 is a typical pregnancy. A baby that is born before 34 weeks is considered to be very preterm. Preterm is less than 37, and then typically a full-term pregnancy is considered to be 38. And for those ladies that might go over by a couple of weeks, up to 42 weeks, typically it's not longer than that. So within this preconception or periconceptual period, this first trimester is really critical for things like folate and iodine. This is associated with an embryo being developed, as opposed to sort of about the 8-week mark where you can start to hear, a heart and so forth, really early into a fetus, and then we're moving into the infant stage when they're born. Prior to 20 weeks, if a woman is to lose their baby, it's considered to be a miscarriage or a spontaneous abortion. And then post 20 weeks, it's considered a fetal death or stillbirth. Okay, so within these pregnancy timeline, there's really specific changes that occur within the female to try and, I guess, nourish that fetus that's developing over time. So there's a really specific and complex sequence of events. So these sequence of events occur, they don't change. So you don't suddenly get one occurring before the other. It's very, very specific. So the first thing that occurs is that the mother has an expansion in plasma volume. And so this is really important because, and primarily it's to do with body water that increases. And this is so that there is an increased flow of blood that supply nutrients and oxygen to the placenta. So the placenta is an organ, and we'll talk a little bit more about that in a minute. But so we have this expansion in plasma volume. We have an increase in nutrient storage that occurs within the mother. And then we have the development of a placenta. And then we have a increase in the flow of blood that goes to the uterus where the nutrients are stored as well. And then we have at the end of that an increase in fetal weight. So you can see that the body prepares itself for the really rapid, or for the rapid changes in the infant, but in terms, it boosts its capabilities first, and then that occurs prior to substantial growth rates within the infant. Okay, so you've got expansion of plasma, expansion of storage capacity, increase in the placenta weight, which is the organ that supplies the nutrients to the fetus, and then you have this increase in the fetal weight. Okay, so everything prepares itself in sequence to make sure that it supports fetal growth at the times when it needs to. So a really critical organ that's associated with pregnancy is the placenta. This actually develops from embryonic tissue. It doesn't develop from the mother. It actually develops from the embryo, and it's critical for fetal growth and development. So essentially what's happening is that we have this sequence of events that's designed to ensure that the placenta is developed before we have a rapid increase in fetal weight. Okay, we need to make sure that the system is in place before we get the outcome. And so the placenta has really key functions. It functions to produce hormones and enzymes, nutrient and gas exchange, and then also regulate waste removal. This is going to be covered in next week's lecture, which will be posted as a recording I've opened up next week. And that's the role of the placentas talked about in more detail next week. Okay, but so you can see here, these are the physiological changes that occur within the mother. So there are a bunch, okay? So it affects nearly every organ and system within the mother. So blood volume expands. As a result of that expansion in blood volume, you get some dilution of vitamins and minerals in the blood. You get a change to lipid levels within the mother's blood, and that's really important because obviously those lipids and cholesterol are then being fed to the infant so that they can have their own steroid hormone production as well. Increase in blood glucose levels. Glucose essentially is the only nutrient that baby takes in and uses in terms of, I guess, a food. So that's really important. You have to have high levels so that you can supply the mother, but then also the infant. We have organ and tissue enlargement, so whether that be the heart, which is then going to be really important for pumping that blood around the body and then also getting it to be delivered to the fetus. So the circulatory system goes through a number of different changes. So the ability of the heart to pump out blood increases, heart rate goes up, the amount of blood that's pumped out increases, and so there's quite significant changes that occur there. The respiratory system, our ability to take in more air and consume more oxygen increases because we obviously need to supply extra to the fetus. Associated with that is that women become hungrier. They have a change to the taste and odour and preference of foods, and there's some quirky things that go on. Increased thirst. They need to take in more water because they need more water within their blood, so that's really linked. Gastrointestinal changes also occur. So this is a really interesting one, and often it's associated with increased levels of progesterone. People become more nauseous. They have more a slowed movement within the bowel. Progesterone kind of relaxes all of those muscles, so fecal matter doesn't move through the bowel as quickly as it can. So that's linked to constipation. The kidney starts to work higher. You've got a higher blood volume, so it needs to filter more blood. It needs to also excrete the waste that's produced by the infant. The immune system, because it's putting in effort into other systems, there's some suppressed immunity and there's some increased risk for some infections within and associated with the urinary and reproductive tract. And then, not surprisingly, basal metabolic rate, so energy expenditure just at rest, is associated or is increased, particularly in the second half of pregnancy when the infant weight increases. And then also that's linked with increased body temperature. So women in later stages of pregnancy often feel hotter. And so they're kind of like, you know, they can't regulate their body temperature as well. And then obviously there's all those hormonal changes that occur. So you can see that there's a whole host of systems that change and the physiology of the mother changes essentially to support and feed the growth of that infant. So it makes sense then that a woman who is underweight is not ready to become pregnant because they just are not going to have the capacity to fuel their body to then fuel the growth of the baby. And so that's why the body changes a person's ability to become pregnant at a lower weight. So that kind of makes sense in those systems that we talked about previously in preconception. So I'm thinking now we've got all of these physiological changes that go on. We are then therefore going to have some changes to nutrient metabolism. So there's really critical periods around when these nutrients are needed. So we'll talk a little bit about the key macronutrients, so carbohydrate. So the key thing to know here is that glucose is the preferred fuel of the fetus. There's really specific transporters associated with getting glucose into the fetus that we'll talk about a little bit more. And these transporters aren't apparent in any other tissue. Okay, but they are in the placenta. And so during the first half of pregnancy, we have increased levels of insulin within the mother. And that's because we want to make sure that we get storage of fat and glycogen in the mother to prepare it for the growth of that baby. Okay, so the first part is about energy storage, anabolic. The second half of pregnancy, there's this increased insulin resistance. And the reason for that is that we want to be able to constantly supply glucose to the fetus. So if we have high levels of insulin, the mother can use glucose for storage. So it converts it to glycogen and fat. But we want to stop that from happening in the second half of pregnancy because that baby needs that glucose. So it wants to stop mum from storing it and it wants to use it. We also have increased protein metabolism. It wants stop mum from storing it and it wants to use it. We also have increased protein metabolism. So protein is really important for synthesis of mother's tissues, right? We have growth in all of these organs, but it also needs to be used by the fetus. And consequently, we have a change to the way the kidneys work. So the kidneys, rather than letting protein be excreted, it works really hard to retain protein so that's available for the baby to use. Primarily, there's no breakdown of tissue by the mother. It's primarily we meet our protein needs through diet. Okay? So the mother doesn't break down muscle or bone or anything to get more protein. It typically takes it out of we typically take it out of the diet. With respect to fat, again, in the first half of pregnancy, we undergo all of these adaptations, or a female undergoes these adaptations to try and accumulate fat. We want to try and store fat, again, so that we can prepare for when the baby needs, or the infant or fetus needs it later on. And in the second half of pregnancy, it shifts to making fat available. So this is really important because so it makes more blood fat available as triglycerides, and it increases levels of cholesterol in blood. That cholesterol is used by the placenta to synthesize steroid hormones, which is obviously really important for the baby or the fetus. And then it's also important for the fetus to use cholesterol for nerve and cell membrane formation. Okay, and so you can see that all of these processes around these macronutrients are about, in the first half, anabolic, which is building, and then it's about, in the second half, it's about release of those nutrients to make them available for the fetus to use. Key minerals that are nutrients to make them available for the fetus to use. Key minerals that change a little bit more include sodium. So there's increased retention of sodium because we need that to support plasma volume expansion. And there's also increased maternal calcium absorption and some mobilization from bone, but essentially the mother increased or upregulates its ability to absorb calcium so that it's then available for the fetus for bone formation. So you can see that we've got all of these systems that are upregulated, and one of the key guiding principles that then is linked to newborn body weight and health outcomes is how much weight the mother gains during pregnancy. Because all of these systems are about accumulation of storage of nutrients so that we can feed that infant, And weight gain is also of the mother. So the mother gains weight as a consequence of storing nutrients, but she also gains weight as a consequence of showing how well the baby is growing, or the infant is growing inside of her. So you can see from this example here that, within the first trimester here, there's kind of minimal body weight change during the first trimester. There's increased gains during the second trimester, and this is probably proportionally where the mother gains the most weight in preparation for these large gains in fetal weight. So you can see this is in pounds here, but you can see that there's a number of tissues that are responsible for this weight gain. So there's increase in breast size, obviously that's in preparation for delivery. Increase in fluid, the placenta organ grows. There's an increase in blood supply to the placenta as well as fluid within that, in the amniotic sac. The infant itself has grown, and then there's also an increase in the size of the uterus and other muscles that are associated with supporting that growth of that fetus in there. The mother also gains some fat stores as well. Okay, so you can see that weight gain is really, really important during pregnancy. This weight gain tends to mirror that of fetal weight gain, so it's minimal as in the first trimester. It's highest in terms of weight gain, the trajectory of it is highest in the second trimester in preparation for this rapid weight gain by the fetus towards the end of pregnancy. Okay, so it's kind of, everything is about preparing to then make sure that the infant or the fetus grows properly. Okay. So there's some recommendations. So the recommendations are essentially based on what a person's pre-pregnancy weight. So if someone is underweight, they're recommended to gain more weight. If they're overweight, they're recommended to gain less, okay? Because if you're overweight, you've already got a lot of the nutrition and fat stores that are going to be able to be provided to the infant. It also has implications for the outcomes of your pregnancy as well. In the next slide, I'll talk about that. The key thing that I've found here is that in Australia, more than half of women gain more than the recommended weight than they need. And unfortunately, women who are already overweight or obese gaining even more weight during pregnancy is really problematic. So it impacts on their health during pregnancy, it impacts on the outcomes of the infant once they're born, and it also has significant health implications for the mother afterwards. It's really difficult to lose that post-pregnancy. And so consequently, gaining more when you're already overweight or obese just means that you're going to carry that weight and continue to carry that weight as you age. So obesity during pregnancy is associated with risk or increased risk for miscarriage, having high blood pressure, gestational diabetes, and also congenital malformations. So that's essentially birth defects within the infant when they're born. And then during delivery, obese women are more likely to be induced to have an emergency cesarean section, which some people are, which means that you have high risk of complications, high risk of infections, because you've got extra fat mass that then covers the wound site, so that increases risks in that for infection. They're also more likely to experience hemorrhage, which is where you have blood loss, which can actually, if you lose too much blood, it's risk of death. And then themselves ending up in intensive care units after birth. So, reduces their ability to care for the infant, reduces their ability to breastfeed post delivery. All of those sorts of things become challenging. So look, the end of this video lecture here is kind of a bit of a summary of maternal changes. I'm going to let you watch that at your own time, rather than showing that here. The link is available there. So essentially today we're trying to set up the scene for why nutrition matters, how that feeds into weight, pre-pregnancy nutrition or preconception or conception nutrition, changes in physiology, and how they're really, they're designed to try and nourish that fetal development during pregnancy. Okay, so kind of a shorter lecture today to give some sort of introductory concepts. The lecture next week is about early origins of adult disease and conception and probably the role of the placenta, really. And then the week after that, we'll come back to pregnancy and talk more about nutrients that are designed to support the physiological changes that we've talked about today. Okay. Okay, is anyone, any questions?
charts there with you. What does the first 1,000 days signify? Nathan? Yep, since conception and up to what age? 1,000, yeah. Now, after conception is, so what year? Trinity's trying to whisper it to you. You've got to listen to her. Yeah, 2 years. Excellent. Okay, so they've labelled it as the first 1,000 days because it's so critical to later development of disease. I think there we go. So pregnancy, year 1 and year 2 is the first 1,000 days. And the nutrition that happens in that time is said to be critical, but what we're trying to get a handle on is how critical actually is it for the development of adult diseases later in life. So by now, hopefully you get how important nutrition is. See, I'm starting to beat up the nutrition side of the degree, right? And its influence on health. We know that a lot of the obesity and allergies are set at this period of time in the first 1,000 days. And if you remember that at least 50% of deaths in our society are related to the food we do or don't eat and the exercise we do or don't do, and then you combine that with the influence of nutrition in those first 1,000 days, you are studying the most important degree in the world, right? It's critical. So 30% of deaths of heart disease are due to diet, 5% of type 2 diabetes, probably higher. Sorry, 30% of deaths are due to heart disease now. 5% of the population have type 2 diabetes. They predict it's actually higher, up to about 10%, but half the people don't actually realise they have it. 65% of adults are overweight or obese. So you can start to see the impact that nutrition has. But the question is are those people that are overweight and obese like that because of what happened whilst their mother was pregnant with them? So did what mum eat during the pregnancy affect the baby's development? And then we have a look at the allergic-based diseases as opposed to the metabolic-based ones, and we have asthma, eczema, allergy, children, both children and adults is quite high. Once upon a time, you would have heard about, who here has children? You? Yeah? Once upon a time, probably not you guys because you were young, we were told to avoid allergic food during pregnancy, but that's now changed. And even if they suspect there's an actual allergy to peanuts, which is the most common one, the mother, unless she is obviously allergic, is encouraged to actually eat, because avoidance of the allergen actually increases the risk of allergy. Okay. So, we're talking about early origins of adult disease. It's also known as all these other things, and I'm not going to go through each of them, but you can see they're sort of all related in some way, the naming, except the last one, which is Barker's hypothesis, okay? And it's named Barker's hypothesis because he was the scientist who first described this as a potential reason. So the learning outcomes for this lecture: explain the evidence that led to the development of Barker's hypothesis, explain it, explain physiological changes that occurred during pregnancy, explain the stages of fetal growth and development, describe the determinants of fetal growth and development, and describe how nutrients are supplied to the fetus. Are people cold? No? Anyone cold? No? Okay. And then describe the impact of undernutrition and overnutrition on fetal growth and development. So it's quite a bit in the lecture. I can't say we'll go slowly if we actually need to finish it today, but we'll go through it. And please stop and ask me questions if you don't understand what I'm saying, okay? That's the best time to work it out. So this is Barker. He's sitting here amongst a whole lot of boxes. No, he's not just been kicked out of uni because of potential mergers or E25s. This is actually all the data that he's collected to describe his hypothesis, and it was described in the Lancet. So he was the professor and director of the epidemiology unit in England. Can anyone recall from first year lectures what epidemiology is? I'll move past you, Joel. I often do this because I feel so lonely downstairs, and it's warmer up here too. That's why you guys aren't cold. Yeah, so it's looking at what diseases occur in certain populations and trying to attribute some cause to it, okay? And he was looking over a disease map of coronary heart disease in Great Britain, and he observed a geographic trend where people in the poorer regions actually had higher levels of coronary heart disease than men in the richer regions. And this was considered a bit strange because at that time, we knew that the rich people who had, could smoke, could afford smoking, could drink a lot of alcohol, who didn't have to do exercise because they had servants, and ate a lot of meat, were actually meant to get higher rates of coronary heart disease. This was a little bit different. They actually had lower rates, and he was confused by it. Because, as we said, men in the poor regions didn't have any of these modifiable risk factors in their lifestyles. So I was trying to work out why. So then he thought perhaps something happened in their earlier lives that could explain it. And he looked to see if he could find maternity records anywhere. And there was one place in the Shire of Hertfordshire, and I'm probably not pronouncing this right, where the midwife there, she's got such a midwife's name, Ethel Burnside, used to keep meticulous records of the baby's height and weight, head circumference when they were born, whether they were discharged on breastfeeding or on an infant on a bottle, the rest of the family, when they came in for visits, how their growth and development occurred. She had incredible records, and he got really excited, as professors do. And so he had data available from 1945 and backwards, and combined with the data he had from the National Health Service, which looked at coronary heart disease, he could look at what happened to them as babies and compare it to later to see their heart disease rates. And so this is a thing with epidemiology, where it was able to look at disease patterns and then look to see what might have caused it. So it was able to retrospectively, and that means follow them backwards. Do you remember talking about retrospective studies? What's the problem with retrospective studies as opposed to prospective studies? Yeah, you can't have a cause and effect because you don't know if it preceded it. But here we sort of do because he's got the data, but it's the quality of the data which may not be good. Because if you're going forward and you say, I'm going to look at birth weight and feeding and heart disease risk for 50 years, you're going to have everything that you want to collect recorded right from scratch. But he was lucky he had good records here. So follow 5,500 male babies. They were in their mid-70s at the time of the study, and he compared it to the British National Health Service. What he found was those babies that were born less than 5.5 pounds or 2.5 kilos actually had more risk of developing heart disease. So they didn't have more risk, they did develop more heart disease than those that were born over 2.5 kilos. So this was a clue for him. Something to do with the baby's weight protected them against heart disease. But why and how was the next question. So that was his theory, that was his hypothesis. Remember, a hypothesis doesn't mean it's true, it's just what you determine. Okay? So I hypothesised, because this isn't being recorded, there will be about 8 angry students tomorrow when they realise this, right? I can set out to find it out by sending an email and saying, circle the smiley face that you have at the moment, right? So that's when I test it. At the moment, it's just a hypothesis as it was with Barker. And what he said from that was that the womb may be more important than the home. Or, to put it in one of his other quotes, that one of the most threatening things about fetal programming, and that's what he thought was happening, something was happening in the womb where the baby was programmed to have more heart disease. Okay? So he said, one of the most threatening things about fetal programming is that it means that God may reward you less than you think for changing your lifestyle. So at the great age of 40 and 50, when you're told you've got risk factors for heart disease, you might go, yeah, I'm going to start running marathons, I'm going to eat really healthy, I'm going to stop smoking, I'm going to stop drinking, and you still get a heart attack. So you weren't rewarded for your efforts. So that's what that's saying, what he's saying is there. Okay, so the hypothesis is that during times of nutrient deprivation, in utero fetus makes metabolic adaptations beneficial to survival postnatally in similar conditions of low nutrition, which means if the fetus is born into a condition of low nutrition, now let me start again. So what it's saying is, whilst mum's pregnant, if there is low nutrition available for her during the pregnancy, the fetus will make some adaptations, genetic adaptations, so that the baby can survive in the outside world with little nutrition. Because after all, the whole purpose, sounds like a deep philosophical thing coming up now, but the whole purpose of life is to ensure the success of the next generation, right? That's evolution. We want to make the next generation more successful. So if during pregnancy there is little food available outside, to best ensure that survival, the baby will be adapted genetically to survive in an environment with little food. So that's why they also call this the thrifty phenotype. You're given a thrifty phenotype to make sure you can survive in that environment. So if the baby is born in that environment with little or no nutrition, it'll be fine. But if it's born into an environment where there's lots of nutrition, it's going to contradict the genetic imprinting that's happened, and it's going to have metabolic disturbances because of that. Is anyone confused by that? Because this is a really critical point. Everyone good? So what could possibly happen where during the pregnancy the mum doesn't have enough food to eat, and then after pregnancy there's lots and lots of food available for the baby? Excuse me. What could cause that? Yep, mum can have an eating disorder, and so the baby's not getting enough nutrition. What else? Famine, yep. So there's a famine, leaving a war-ravaged country, migrating over to Australia. They have a baby in Australia, and look how much food we've got here. Okay, so that's probably the most common one. Common reason. The other thing that they've noted recently is that Ramadan fasting affects it in this way as well. Now, a woman isn't meant to be fasting if she's pregnant, it's Ramadan, but if she doesn't know she's pregnant yet, how is she to know? Okay, so, you know, there's lots of things that could be occurring. Poverty, little access to food, you know, and then it changes, a lot of things. Okay, so what we've got here is an abnormal maternal metabolic milieu, and there's an in utero insult. It could be because of adverse maternal nutrition, it could be because of placental insufficiency, and we'll go to that, where the placenta isn't working properly. It results in poor fetal growth and abnormal metabolic programming, and here you've got similar in utero and postnatal environments, low risk of developing diseases. If you have conflicting environments, a high risk of developing metabolic diseases. Okay, so this is really important, this slide. You know, if you get this concept, you're halfway there with this lecture. Has everyone got it? Awesome, we can only do another 15 minutes of lectures and then we're done. Okay, so any other evidence? Well, studies in Norway, Finland, Britain and the US have similarly shown that death rates from coronary vascular disease are inversely related to past differences in infant mortality. Okay? So it's not just what we saw in Hertfordshire and Barker, they've seen in other cases as well. And case control studies have generally supported that patients with MI, myocardial disease, and the US have similarly shown that death rates from coronary vascular disease are inversely related to past differences in infant mortality. Okay? So it's not just what they saw in Hertfordshire with Barker, they've seen it in other places as well. And case control studies have generally supported that patients with MI, myocardial infarction, have higher infant death rates among their siblings, or are more likely to come from larger families and have fathers that are underemployed. What does this mean? Why is that relevant? Yeah, there was less food available. Okay? So, and in the Dutch winter hunger famine, which occurred in a really short period of time, from September to May, so 6 months it was, maybe a little bit more, what they found, and this is a picture from that time, and this is the kitchen. What can you see about the kitchen? Filthy, yeah. Is there much there? No, everything was burnt for to produce heat. Okay, so there was a famine, and they were actually just burning all the inside bits of their homes to try to keep themselves warm, and anything that could be eaten was eaten during that time. So it just indicates the severity of the famine in a short period of time. And what they found that those pregnancies where the timing of the famine exposure was either early or mid, so the first 3 or 6 months of the pregnancy, these were the problems they had: abnormal development of reproductive systems in the babies, and then cardiovascular disease in adult life. If the famine occurred in the late stage of the pregnancy in the women in Holland, they had fetal growth restriction, adult obesity, and type 2 diabetes. So it seems that there's different adaptations occurring at different time points depending on when the different organs are developing. So critics of it, and you've probably worked out now at uni, there's always critics of everybody's research. The critics of this research say that he ignored data that didn't fit his hypothesis, and they don't explain why women who consume a normal diet will still have other low weight influences. But clearly, so have low weight babies, but there's clearly other influences. What's coming out in the literature in the last few years is that the male's diet is also incredibly important. And the other one thing we know about pregnancy and paternity is that roughly 10 to 20% of people, their dad isn't who they think it is. Okay? Now some people go, phew, when I say that, other people go, what? But that's about the rate we're dealing with, okay, in Western societies, I don't know where else. So, you might go, the father had a healthy diet, but the husband had a healthy diet, but you don't know what the father had. Okay, so there is a problem with that. I'm not laying blame on any particular party, it's just the stats there. Experimental studies have also been done in animals, and that data is repeated there. Why wouldn't we do these in humans? Exactly, thank you. They're not ethical. So that's the only place we're going to get data from. Normally we say, before we prove something, that we want to see it being done in humans, but we're never going to get that. And I guess some of that data comes through with things like Ramadan fasting, but once again, that's not experimental, it's observational. Okay? Remember the difference between observational data and experimental, where observational data doesn't give you cause and effect, it only gives you, potential relationships that may exist. Okay? Any questions at this point? No? Okay. And so evidence from sheep and rats indicates that if you produce very minor changes in the maternal diet, it does affect the offspring, and rats born to mothers on low-protein diets grow smaller livers, have smaller kidneys, and have less flexible blood vessels. And the reason why flexibility in blood vessels is good is because it maintains your blood pressure down low. Okay? So if you've got something that, if you think about, you're trying to transport one fluid from one space to another, and it's going to have varying volumes that fluid's being transported at, if you've got a rigid steel pipe, there's going to be increased pressure when there's more fluid trying to get through. If you've got elastic pipes, the pressure's going to maintain the same as it swells and contracts and dilates as the blood vessels do. That's all physiology, right? You guys know that better than me now, so. Okay, so looking at the physiological changes during pregnancy, critical windows of development, we've already sort of touched on that with what happened in Holland, the factors involved in fetal growth and nutrients that are required for fetal growth, and the role of the placenta. Okay, so these are, for those of us who've been lucky enough to have babies, we can probably interpret this. This is the week number here. The month number, when the woman has the periods, last menstruation, actually occurs at the beginning of week 1. So strictly, when a woman says she's 8 weeks pregnant, 6 of those weeks she's actually had a child within her. The first 2 weeks there was nothing. So the first 2 weeks is before conception occurs. Okay, it's just the way that we date it in medical terms so that everything is consistent. Okay, so is everyone good with that? Yeah. Some of us, it's giving us bad memories, right? So week 2 is when fertilisation occurs, and then we've got each of the trimesters. The development of the embryo is in the first trimester, and that's when you've got early fetal development, primitive organ systems appear, and the placenta begins to develop. In the second trimester, you have the development of the organs and the organ systems. In the third trimester, you have rapid fetal growth. That's when a lot of the baby fat, the fat gets onto the baby. With the deposition of fat tissue, organ systems become functional. And the perinatal period lasts up to 28 days post-birth. Okay? So if you need to take a newborn into hospital because something's occurring, it will go into the mum section up till they're 1 month old, because they're still considered a dyad with mum. Okay? And this is what fetal growth looks like. So the first trimester, these are the 4 stages that occur. You get cleavage, implantation, placentation, and embryogenesis. Cleavage is a sequence of cell divisions that occur after fertilisation. It's the zygote develops into the blastocyst. You've done this in physio, haven't you? Did you do it in physiology? No, okay. Implantation, the blastocyst attaches to the uterus and starts to invade into the maternal tissue, and this is when the placenta starts to form, once it's been able to invade into the maternal tissues, and the placenta forms. And then embryogenesis is the formation of the viable embryo and the basic rudimentary organ systems that occur at that time. Oops, sorry. So you see here, the embryo in the first 8 weeks, week 4 and week 8. Here you can see these very rudimentary systems that have occurred. It's almost the size of a jelly bean, so very, very small. And here you see at week 8 where the placenta has started to form. And a much more developed looking baby. I tend to call the embryo baby, it's just me, okay? So just bear that in mind as we go through this. I use baby interchangeably with fetus. Excuse me. So the fetal period is 8 weeks to 40 weeks. It's the final development of the organ systems. As you progress through the pregnancy, the organ systems become functional and able to support the baby, and there's rapid growth that occurs in this time. It's so much colder down there. It's like nice and warm up here. I'm going to sit here next to you. No, I'm joking. So in the second trimester, there's about 0.6 kilos that goes on with baby weight, and then the third trimester is 3.2 kilos. So big differences. That third trimester is really when all the fat gets laid down, making the baby ready for coming out. I got a comment me doing that. This is a small slide, isn't it? Can you guys see it better? Not very nice, am I? I should make that bigger. This is where what you've got to know is that different organ systems occurring at different times during the development of the fetus. So the different months, and the red ones are critical periods. So if there's some insult at that time, and it could be undernutrition, drugs, alcohol, viruses, bacteria, those organ systems will be the ones that are affected. Okay. I'm trying to remember which way. I think I've got to go up to fix this up. I've got to walk past the thing. So you can see there in the red, if an insult occurs then, that's when the problem is. Have a look at the central nervous system. When does that start being developed? Can you see? Yeah. So tell me what mum knows at week 3. No, she doesn't, does she? She doesn't know she's yet pregnant. So she's week 3. She's not even aware that she's missed a menstruation. So that is the reason, as you get into your further lectures, why alcohol, there is absolutely no alcohol level that's recommended during pregnancy, because, well, we don't know when we're pregnant, and also because of the impact it has on the central nervous system. And you'll see fetal alcohol syndrome. This is where I'm saying, oh my God, I'm missing those lectures already, is a big problem in pregnancy, and they actually recommend none. Okay, the other thing, what's the other nutrient that's important for the central nervous system? Can you? Yeah, folate or folic acid. So once again, mum doesn't know that she's pregnant, and the risk of neural tube defects is really quite high if mum doesn't take supplemented folate. Does she need to take supplemented folate? Have we got something else in place in Australia? Okay. Yes, so the mandatory qualification of folate in bread, which started in about 2009. So, because a lot of women don't know they're pregnant, we put it in the bread to reduce the risk of neural tube defects that way. Although women that are planning pregnancies are recommended to take folate a month before they conceive. But in reality, this is going to scare you all now, because 1 in 2 pregnancies are totally unplanned, right? We don't know when we could get pregnant, so that's, I'm probably stopping to myself at my age. You guys won't know when you could potentially get pregnant, right? So that is why it's actually recommended that women of childbearing age actually take folate supplements. Okay, but in reality, that doesn't happen, and that's why we put it in the bread. Anything else that's in bread that you're aware of? A little spot test. Iodine, and what's that there to reduce? Yeah, thyroid problems, and once again, cretinism, preventing cretinism developing in infants. And one more nutrient that's in bread, Joel, do you know? Thiamine, and that's to prevent alcoholic encephalopathy. Why do we put them in bread? Yeah, everybody eats bread, right? And it's actually in bread flour and not bread, so it's also in any product that is made from bread flour, which can include pizza bases, cakes, biscuits, crackers, etc., etc. Are you aware of any type of bread that doesn't need to have it? Any type of bread flour that doesn't need to have it in there? Organic, yeah. So with this push for women wanting to eat organic during pregnancy, it's actually more risky for them. I tried explaining that to the bakers at Foodland, that they should go back to, and the lady just was staring at me going, what? I thought, just shut up, Evangeline, and move on. Anyway, so you can here see all the critical points. So you can see if there is, malnutrition occurring at the development of the heart, that the heart may be weakened at that point. It's a bit like going, I'm making food and I'm not going to put all the ingredients in the cake, so the cake will still turn out. But if it's a fruit cake and you don't put fruit in it, it's no longer a fruit cake, right? So it's not its optimal, okay? So that is what's happening here with each of these critical points. The fetus requires a supply of nitrogen, carbon, all the other ions and water for normal development. It's used to form new tissue, to deposit fuel reserves like glycogen and fat, and it also needs to produce cellular energy for its metabolic function and respiration every day in the womb. Total nutrient requirements for the fetus depend on its growth rate, its body composition, and its metabolic rate, just like it is for humans, for us outside. They say that, this first statement's a bit obvious, but early development fetal growth is determined by genetic factors, about 40%, and the other 60% is dependent on the environment. So what exercise it's induced to, the temperatures it's induced to, any other insult or injury that occurs, sickness, illnesses, another half of the time. But what we definitely know is that severe nutrient deficiency get fetal growth restriction. Okay, we've seen this period of rapid growth that occurs, and you can see here in the graph how quickly it occurs in that last trimester. So the baby gains 15 grams per kilo of its body weight per day from 24 to 37 to 39 weeks, and in the last couple of weeks it gains 6 grams per kilo per day. Why is there a drop? And I don't want the ones that had babies to tell us, because they know exactly why it's dropped. It's probably a clue to the rest of you now. Why does it drop? So you get the baby out, right? The baby has to come out, and if it keeps going at that rate, it'll all be seizures, okay? So it needs to stop growing. And what happens in those last couple of weeks is you get the maturation of the final organ systems, particularly the lungs, where they're able to breathe independently outside. So factors that affect maternal growth. Maternal factors, mum's size, her nutritional level, does she smoke, any drug abuse, and if she has anemia, what causes anemia in the diet? Yep, awesome. And then the placental factors affect the baby's growth, the size of the placenta, how good the blood flow is, and how efficient it is at moving oxygen and carbon dioxide and all the other nutrients in and out. And then the third factor that affects the baby is the baby itself. So its genetics, because remember it's got half of dad's genetics, its nutrient production, how much nutrients can the baby make itself, its hormone levels, and its growth factors as well. Okay. Any questions there? No? Okay, so the birth weight of the baby is always positively associated with the maternal glucose levels. Okay. What affects mum's glucose levels? Yep, of what? Yeah, carbohydrates, is that it? Think by Ken. That's, yeah, everything remember gets converted to glucose. So it's her diet, but most importantly and most quickly, it is her intake of carbohydrates and sugars that will affect it. And we'll be exploring that a little bit more. Does mum sacrifice everything for the baby? She does in a way. A lot of the nutrients, if mum is devoid of them, it will preferentially go to the baby depending on how it's transported. So it is really critical that mum's nutrition is looked after both for the baby and for her recovery afterwards, and her ability to reproduce more kids afterwards as well. How do nutrients reach the baby? Everyone should be able to answer this. Placenta. Yep. Oh, and here we go. I should have warned you for those that we go, oh. This is the placenta on the left. It's a real one. You can see the hands there next to it to show you how big it is. And then you can see in the picture next to it the size of the placenta in relation to the baby. And you can see that it's actually quite big, and it is considered an organ system. In some countries, they actually consume the placenta after the birth because it's got a lot of, what nutrients would it have in there? Everything, yeah. It had protein. It would have a lot of iron. This is really the good bit, isn't it? And why would mum need iron? Yeah, they lose a lot of blood during the birth, okay? So in a lot of countries, they do save it and eat it. Do we need to do it here in Australia? No. Okay, there's people where you take your placenta and they freeze dry it for you and they make it into a powder and you put it on top of your Weet-Bix every morning. Do not do that, okay? Because why? Why shouldn't you do it? There are other readily available sources, but perhaps you're really environmentally concerned and you want to recycle. Why even then shouldn't you do it? Because the people that are doing this are backyard lab people that have got no ability to ensure the product they've given you isn't infected. Okay, and remember, it's an organ. Once it comes out and it's no longer sterile, and there's no longer oxygen pumping through it, it's going to decay with bacteria it's been exposed to. So, yeah, you get a hold of nutrients. You might also get E. coli, salmonella, and bacillus at the same time. So, not a good idea. Okay, and don't surprise your friends with a placenta dinner party and then tell them afterwards they're eating your placenta. Like, seriously, you're not going to have friends anymore, right? So, yeah. So the placenta evolves from a tiny mass of cells into an organ, which is a complex network of tissues and vessels. It supplies oxygen and nutrients to the fetus. It removes carbon dioxide and waste products. It's a metabolically active organ that produces enzymes and hormones to keep the pregnancy going. And the placenta also protects the fetus from a lot of toxins and drugs, but not all of them. Name me a couple that you should know of that it doesn't protect the baby from. Alcohol and nicotine, yeah, caffeine, yeah, all of those aren't protected. It also stores glucose, okay, in times of blood glucose levels going down. And it has a structure a bit like the intestinal villi and the lungs, in which they're, huge surface area to allow the very quick exchange of nutrients and toxins between mother and baby. Birth weight positively correlates with placental weight in all species, so the bigger your placenta, the bigger your baby. Reduced placental growth results in a reduced fetal growth, obviously, they're related. And fetal growth is highly dependent, we've said that, and placental dysfunction is the most common reason of why you get fetal growth restriction in the world. Oops. This is a new clicker and it's very quick. Fetal factors, as we said, it can regulate the fetal growth independently of mum and the placenta. It has its own thyroid and pancreas and kidneys, which are able to produce hormones and promote fetal growth. If there's an insulin deficiency, it reduces fetal growth. Why? Think like him. Yeah. So glycogen, but why do we need the glycogen? Yeah, why do we need the glucose? I think go round and round.
Energy.
For growth, yeah, it's for energy. Remember that glucose is converted to energy to make things grow. So if there's an insulin deficiency, the baby's growth rate will be low as well. And thyroid hormone deficiency in the baby also reduces their body weight as well, and abnormally develops their tissues. So fetal factors, these are anabolic ones, and to remember that anabolic makes the body grow. It's a bit like anabolic steroids that, bodybuilders use. So these are the three hormones that make the baby's body grow: insulin, thyroxine, and the insulin. Growth factors, and those that reduce fetal growth is the glucocorticoids, which also promote organ maturation, and they happen in the last 2 weeks of the development. If a woman goes into early labour before 37 weeks, they go into hospital as quickly as can, because you're going to go there anyway, but they give them glucocorticoids to also mature the lungs so that the baby can breathe on its own, because the more independent you make the baby on delivery, the better chance it has of survival. So that's an important thing. Here's the placenta, and it's just got a picture here to show you the blue and the red, a bit like we depict in the lungs of the oxygenated and deoxygenated blood, and how it interfaces with the fetal capillaries with the maternal capillaries. Okay, is there an exchange of blood? No, it's just the surfaces are so thin that this is where you get either diffusion or active transport or passive diffusion of substances across those really, the one cellular thin areas to allow it. So nutrients are supplied to the fetus via 3 ways. So placental transfer from mum to baby. Placental synthesis and then baby synthesis. But the main source of nutrients is the mum's supply. And this is the different ways that substances can be transferred. This is just one of those slides that you're going to have to learn, right? There's no easy way for me to explain it. Passive diffusion is oxygen, carbon dioxide, the fats, the steroids, fat-soluble vitamins. Facilitated diffusion is active transport. Sorry, let me start that again. Sugar goes by facilitated diffusion by the GLUT4 receptor. Active transport is the amino acids and the cations and some water-soluble vitamins. Solvent drag is the electrolytes. The important ones to know is obviously all the macronutrients and also glucose, and we'll talk about that more. So the rate of nutrient transfer, if we look back on this, depends on the concentration of these solutes and these products either side. So role of nutrient transfer depends on maternal fetal concentrations. Placental transfer capacity. In normal pregnancies, the placental transfer should exceed the requirements of the baby, okay? Because you always want to have more ability than you need to supply the baby right throughout. In the early pregnancy, placental growth exceeds the fetal growth. In the second half of the pregnancy, the fetal growth exceeds that of the placenta. But at each time, the placenta should be able to provide more than the baby needs. The placental transfer capacity increases in later gestation, where there's increased surface area and also increased expression of transporters, which allow the transport of nutrients across from mum to baby. Do you guys want to have a break? Wiggle your legs, it's about to sit. Yep, shake around, all that sort of stuff. 5-minute break for everyone. And we'll start with glucose transfer. There's a lot of slop around, all that sort of stuff. 5-minute break for everyone. And we'll start with glucose transfer. There's a lot of slides, isn't there? But it's pretty easy. Says me, please. Get up, wiggle around. You know sitting's bad for you, right? Have we got any double degree students in here? Yes? What's your double degree with? Excellent, you can tell us all about it. You're really glad you told me that now, aren't you? If anyone's ever doubted that hot air rises, it's just going to come to the front. It is extraordinary. I'll make you play the hokey pokey unless you want to. I've never done that before in class. That could be fun. Okay. Oh, yes, sorry, I'm not going to do that. Oh, yeah, so you're the last cohort. I know. What's the worst thing someone's monogrammed? Okay, well, since we talked about the elf, one of the elf's favourite drinks was Coke and soft drinks in that movie, wasn't it? And putting lots of chocolate syrup on his bolognese and eating Cocoa Pops and all sorts of things. So what do all those products have a lot of in them? Sugar. Look at that, perfectly timed, isn't it? Segue, perfect. Get you guys back on track. So, glucose is the preferred fetal substrate for energy. Okay, remember the fetus needs it, and it's transferred by facilitated diffusion from mother to fetus. And it uses a transporter called the GLUT1, really original name, glucose transporter 1. And the rate of glucose transfer across this increases as the gestational period goes on, which makes sense because the baby needs to get bigger and fatter. And GLUT1, the transporter, is expressed both on the mum side and on the baby side of the placenta. So, in terms of amino acids, it's expressed on the mum side and on the baby side of the placenta. So, in terms of amino acids, most amino acids are derived from the maternal circulation and they're transferred by active transport, and the fetal concentrations are higher than in the mother, and that's because the baby is making so many new tissues and organs and hormones and everything, and it needs amino acids for that, so it has to be higher, and that is why it has to be active transport, because if you were relying on the concentration gradient, it would never happen. Okay? So it's active transport across to keep the amino acids higher. The placenta also metabolizes specific amino acids and releases them into the circulation. Intrauterine growth restriction is what the acronym is for. It results is because of reduced activity of the amino acid transport system. And amino acid transport is impaired by nicotine and alcohol, okay? And hence why those women tend to have small babies, which we now know is bad because it sets up the baby for later disease in later life, right? Lipids are required in high levels to support the fetal growth. Which bit of your body, okay, let me start again. Which bit of the body of a normally thin person contains the most fat? So with you, Nathan, you're not overweight, right? Where is most of the fat in your body? Or a big concentrated source?
Stomach.
No, 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 no. Think about it. Think about it. What was that, Agatha? Oh, no. Thanks. Okay, that is an immediate F for you. No. No, that's not an organ. No? Think. Yes, the brain. The brain is made up of all fats because of all the cells in there. So we need a lot of fat going to the baby, and it's a special type of fat. And I know you guys hate hearing about the special research interest of the lecturers, but I like omega-3 fatty acids, right? And your brain is mainly made up of omega-3 fatty acids, and in particular one called DHA. And women make more DHA than men do for the very reason that they've got to give it to their baby so that the baby has a brain, right? So free fatty acids are permeable. Transfer does depend on the maternal fetal concentration gradient, and there was also the ability for the placenta to make to change medium chain triglycerides into longer ones and transfer them across to the fetus. So lipids are also important. The placenta makes its own stuff as well. It makes glutamine and glycine, which are those there, and it metabolizes them from the maternal circulation. The placenta can synthesize free fatty acids and cholesterol, and the placenta can synthesize free fatty acids and cholesterol as well, and then the substrate interconversion also happens in the placenta, where it can go from fats to sugars to amino acids. Now, we've seen the role of the placenta. Placental dysfunction, there can be different types. Insufficiency, where there's decreased blood flow. Placental abruption, where the placenta detracts from the uterus. This is quite dangerous and life-threatening, obviously. Placental privia is when the placenta attaches low in the uterus, and ideally you want the placenta to be high up so it doesn't keep getting knocked on. And you certainly don't want the placenta attaching at the cervix because it's got the risk of falling through. And then you can have an infection of the placenta which can pass on to the fetus, and that's what we get with listeria, which is not a bad infection for the majority of the people, but for pregnant women it's quite dangerous, and we'll learn more about that in food safety and regulation. So this is a placenta. Normally you want the placenta up high, well attached. You've got the placenta down here low. It's got a risk, because the cervix opening is there, there are points in which it can't attach, so it means there's a greater risk of it detaching if it's low down. And normally if they find a woman has this, it's bed rest for it to reduce the risk of that happening. Placental insufficiency, it won't supply enough of any of the things it needs or get rid of the toxins as quickly as possible. And not surprisingly, it leads to intrauterine growth restriction. And if it separates, obviously that's going to be problematic too. And that I think is self-explanatory, so I'll just leave that so we get through the rest. Okay, so hormones of the placenta. Remember, the placenta can also make hormones, and it makes one, it maintains the pregnancy and it also prepares the breasts for lactation. So you have different types. The human chorionic gonadotrophin maintains the corpus luteum of the pregnancy up to around 10 weeks until the placenta is able to take over and supply nutrients to the baby. Thereafter, the placenta continues producing estrogen and testosterone. The human chorionic gonadotrophin also stimulates secretion of testosterone by the Leydig cells in the testes of XY embryos, and this is the hormone that's picked up in pregnancy tests. And it's higher if you've got twins, or even higher if you've got triplets. Anyone here had twins? No? We're all lucky. Estrogen is also made. It matures the mammary glands for lactation, and the placenta extracts DHEA from fetal blood and converts it to estrogen. I've got this in a diagram. Progesterone suppresses uterine contraction, so stops the woman from going into early labour. It promotes formation of the cervical plug to prevent uterine contamination. So when they say the mother's had the show, they're referring to the cervical plug having come out. The human chorionic somatomammatropin, and that reduces maternal use of glucose and promotes it to be stored as fat for later supply when breastfeeding. I don't do the breastfeeding lecture, which I'm really disappointed about, because I don't get the chance to go on about how important breastfeeding is. If there is one thing you do for your kids, breastfeed them, okay? And dads, you are equally responsible for supporting your partners in breastfeeding. So here we mentioned DHEA, and that is dehydro, that one there, okay? You don't need to know that for the exam. DHEA is adequate. So in the maternal blood, you have cholesterol. Cholesterol is transferred across to the placenta. In the placenta, the cholesterol can be converted to progesterone, and that goes back out to mum's circulation. Okay, the cholesterol can then be moved from the placenta into the fetal blood, eaten to the fetal adrenal cortex to produce DHEA. That gets then transported back out into the placenta where it gets converted to estrogen, and the estrogen then goes out to keep mum from going into labour and also maturing the mammary glands. So you can see how all three work together to maintain the pregnancy. Okay. As a result, if you ever take cholesterol levels in a pregnant woman, they will be really high. And it's because the cholesterol is made and used to maintain the pregnancy and converting it into all the hormones. So the first rule is you never worry about taking cholesterol levels from a pregnant woman because they're just going to be really high and not going to reflect what's normally happening. Okay. Any questions about that? All good? So, estrogen and progesterone and how it prepares the breasts for lactation. Breast in non-pregnant females is mostly adipose tissue and has a very rudimentary duct system. So if you've not had a baby yet, you've still got baby boobs. Okay. The estrogen, the progesterone, the prolactin, the human chorionic tongue twisters, somatomammatropin, all contribute to mammary gland formation. The estrogen promotes the ducts from developing within the boobs. The progesterone stimulates the alveolar lobules to form, which produce the milk, and the prolactin and the HCS induce the synthesis of enzymes that are needed to make the breast milk. So once again, the baby is preparing the boobs for its future feeding. Okay? And remember, breastfeeding is critical. Remember, everyone here except for Nathan is going to be breastfeeding, right? The chest wall here, then you've got the muscles over here. The yellow bits are the fat that surround the tip of the boob. In here are the lobules that make the milk, and then the ducts which go out to the nipple to then be supplied to the baby. Fat development in the baby also occurs as a mixture of white and brown fat. You'll learn more about that in UNIM. I'm just mentioning it to let you know that the brown fat's in the baby to keep them warm in case they're delivered and to ensure their survival after delivery. Because remember, in an evolutionary term, babies weren't born in hospitals with blankets, they were born wherever, and mums could have died as a way of giving the baby some extra hours of life. Okay, fetal fat development changes. So body fat levels increase. The human fetus accumulates more fat later in birth, and an increased fetal glucose supply means an increased fetal fat deposition near term. Birth weight and neonatal fat mass are positively associated with maternal glucose levels. And we now also appetite. The appetite regulating neural network is present before birth, and the circuitry of our appetite begins here. So in animals who are given what they say cafeteria-based diets, those babies that are born from those animals have a preference for cafeteria-based diets thereafterwards. So basically it's just a standard animal chow, but they add a lot of saturated fat and sugar to it. And those animals whose mums ate that type of food prefer that when they're born. So also indicating how important the type of food that mum eats is on what food preferences the baby has later in life as well. Okay, so it's all influenced. At this point, I don't want you guys going home and blaming your mums for everything that's now happened to you, why you like chocolate and you don't like whatever, but yeah. And newborn infants can regulate appetite and feeding requirements at birth. And if you measure the amount of breast milk a baby takes or the amount of food a baby has, it is almost to the same kilojoule level every 24 hours. So babies have the ability to regulate their appetite system really well, much better than adults do. Okay? And breastfeeding actually helps that. I'm sneaking things in from the other lectures. I'm upset I'm not teaching that. Lambs born to overfed mothers have a greater feeding takes after birth. Okay? The system is set. And infants of obese mothers who are obese before pregnancy have a higher risk of being obese in adulthood as well. And so we've talked about this already. Okay, so the impact of under and overnutrition on fetal growth. Now, early origins of adult disease, it goes back to what we've looked at all up to now. Different patterns of fetal and neonatal growth associated with long-term effects and risk of specific diseases. If there's intrauterine growth restriction, it's associated with increased risk of these diseases. Now, how is this happening? Women who are overweight or obese give birth to heavier infants. Heavier infants increases your risk of child and adult obesity. Maternal diabetes increases fat deposition before birth and obesity in later life in babies. And maternal junk food diets increases taste for junk food in offspring. So here's what's happening. Mum is eating a lot of food. In particular, she has a thing for Krispy Kreme donuts, okay, or lots of lollies. So what's in snakes? Lolly snakes. Sugar. So mum eats a whole bag of them, 200 grams. What happens in a body? So if you eat a whole bag of snakes, what will happen to the blood glucose levels? Mum eats a high sugar diet, okay? And it's got to specifically be a high sugar diet. So mum eats lots of snakes and marshmallows and Krispy Kreme donuts, and her blood glucose levels go up. because of the concentration gradient between mum's blood levels and the baby's blood levels. There's a concentration gradient. So through the GLUT1 transporter, it goes to the baby's blood. Baby's blood glucose levels go up, right? Insulin is released to convert that because we want to keep the baby's glucose levels at that safe range again. Yep. Baby's levels are maintained by either being converted to glycogen. Once glycogen is maximised, it gets converted to fat. Baby deposits fat, which is good to a certain point because you want a little bit of a baby fat. But if this continually happens, the baby is born obese, and then what's happening at the genetic level? What it means is it's starting off obese, more likely to have childhood obesity, adult obesity, and then get the later diseases that are coming from metabolic disorders. So you can see the risk, the pattern we're in this society, where there's a continual overconsumption, and we've got one generation priming the next generation, because as well as having this increased glucose level, what else is happening to the baby that we've just learnt about? Neural pathways are forming to say, hey baby, you're going to have a big appetite, eat more. Okay? And it always amazes me when they show that the biggest baby that's ever been born, you go, why are they advertising that? It's seen as a good thing. And so long as the baby's over 2.5 kilos, that is a good thing. What is the problem with the 2.5 kilo babies and under? The metabolic programming to survive in a world without a lot of food. And then if they're born in that environment where there's lots of food, they can't handle it properly, so they're also more likely to be obese. So what do we learn? Either overnutrition as an infant or undernutrition as an infant leads to a metabolic milieu in the baby, which sets it up for obesity or coronary heart disease later in life. But there's a lot of pressure on mums, pregnant women, to eat the right food before this. And now we're saying, hey, something else you need to worry about. Early origins of adult disease. You know, and if you overeat, you're going to teach your baby to overeat. There's a lot happening here in pregnancy. It's about getting it right and the nutritional information. And if there's a point where women may feel susceptible and heed advice, this could be the time. So here we see just the evidence to back it up: high maternal BMI, high birth weight. There isn't a more perfect graph than the one that has got this on the bottom and diabetes here. Okay? Gestational diabetes is like a woman overeating in pregnancy, because in gestational diabetes, the woman is having trouble converting her high blood glucose levels to glycogen and whatnot, and she's got to watch it carefully. In some cases, they have to take insulin. And the reason they take it so seriously is this risk of high birth weight. And what is, aside from the effects later in life, which we didn't know about 20 years ago when you guys were born, what is the risk of a really heavy baby at pregnancy? The risk of a C-section. In today's world, we think C-sections are good, but they're not. Recovery time is much higher. Okay, there's more risk of death to both the baby and the mother, and there's risk of infections and all sorts of things. So it's not a good option. So yeah, the reason why we want to keep those BMIs down. So here we go. This is just going through what we said. I think you all know it now, don't you? So gestational diabetes and the programming of obesity, it's the same story. This is what we call a tomato baby. They call them tomato babies. They look so big and chubby and like a tomato that's over ripened with water and it's about to burst at the seams, and it's also quite red. Gestational diabetes, the same story as it is with eating too many snakes, Krispy Kremes, and whatever else it was I said. Increased glucose concentrations in the maternal circulation, glucose and insulin, increased fetal fat deposition, and increased infant adiposity. Leads to multiple pregnancy complications, including macrosomia, which means a big body, birth weight over 4 kilos, and increases C-section delivery, increased risk of obesity in later life, and increased risk of adult metabolic diseases. This is a normal baby, and this is a baby that's got fetal growth restriction. What can you tell me about the difference between those two babies? Small, like small for size, but what else? Leaner? You don't see the fat on it, do you? And proportionately, the head looks a bit like an alien, doesn't it? And that's because it hasn't had that opportunity to put down fat, which is important to keep it warm, and also for an energy source. Because the first 3 or 4 days of life, the baby doesn't actually feed much, it doesn't get much breast milk in, so it's relying on its own body fat stores. And when a baby is discharged from hospital, normally, a normal baby will have dropped a little bit in their weight because they haven't had the opportunity to feed much. Not a huge drop, just a little bit. What we have is disproportionately grown, so this baby could have been like that and chubby, and you wouldn't notice it if you looked at him without another baby next to him, because he's just proportionately small, but got the fat on him. Whilst this one's proportionally small and doesn't have the fat deposition on it that you need. Yep, so you get 3 to 7% in developed countries, and it's lower in underdeveloped countries, and there's an increased risk of neonatal morbidity and mortality with it. And they also now, to check for this, they check with ultrasound scans throughout the pregnancy. So if they're concerned about growth not being proper, they will do ultrasound to see what the length of each of the bones are, and they can guess from there if the baby's growing proportionately well. For this, what's a really important thing to know, because you see that popping on these charts. Have you ever seen these growth charts before? These growth charts, see how they have the lines on them? So if you're born on the very top line, or at 10 weeks of the pregnancy you're on that line, you should follow that line for the rest of the pregnancy or the rest of childhood. If you start dipping down, it means that your growth's been affected. If you start on that 10th percentile, you should follow the 10th percentile line. Bearing in mind that if you're under 10%, you've got growth restriction. But what is a really important piece of information to know before you can say they've had intrauterine growth restriction? If the parents are little, the kid's going to be little too, right? So that's an important thing to take into consideration. That's where mum and dad's height rate is important. They also look at organ size. So are all the organs growing at the same time as well? Has one particular organ been affected by lack of growth due to one of those critical periods I showed you right at the beginning of the lecture? Okay? So all of this is monitored in the pregnancy. So maternal causes of fetal growth restriction include high blood pressure of mum. Why would that cause fetal growth restriction? The high blood pressure means that the blood flow rate to the baby will be reduced. Chronic kidney disease in mum. Why? Yeah, can't filter the blood properly. So if you've got chronic kidney disease, you're not filtering out all your toxins, you're leaving some of the toxins behind in your blood, depending on the concentration gradient, and if the placenta screens them out or not, you can get transfer across to mum. Diabetes. Now, this is a bit of a funny one, so I just said it could cause both. here I'm saying it could cause growth restriction. Once again, it may affect, depends how long the mum's had diabetes, but a mum in her 40s who's had been a type 1 diabetes for 30 years will have started to have developed vascular damage to all her blood vessels, and so she won't be able to transport blood as efficiently to the placenta. The placenta may also be affected. This is one of these stories that I don't know what I like telling, but it just signifies how much has changed in 30 years. I finished dietetics in 89, in 90, right? And I remember in our lecture, we had an endocrinologist who's a specialist who looks after patients with diabetes come in and talk about diabetes to us. And he's telling us about type 1 diabetes, which is insulin dependent, which you can get at any age, and then type 2 diabetes, which is the one that most people have now. And back then, it was people over 65 who got it. And they got it because their body was just starting to wear down, and as you get older, things don't work as well, and one of the things that doesn't work as well is producing insulin, right? So, and he said to us, he goes, type 1 diabetes you can get in any age, type 2 diabetes you will never, ever, ever see in under 65-year-olds, ever. Because it's a disease of the old person because their pancreas isn't working. I then, before I started here, was working at REPAT, and I was looking after the diabetes clinics there, so I was seeing all the diabetes patients. And my last patient I saw, I swear not, very last patient, that last Friday, working at REPAT, was an 18-year-old girl, so your ages, right, who had type 2 diabetes and was on insulin. And I just sat there going, oh my God, in the space of 20 years, look what's happened. Now, with type 2 diabetes, what happens is if it's, diagnosed at the age of 70 in an elderly person, normally we see all the risks that are associated with it, like the peripheral neuropathy, the vasculopathy, all of those things, might happen 20 years down the track. And so for a 70-year-old, they'll be 90. Okay, and most are lucky to get to 90, right? So we didn't largely worry about all the problems that happen with diabetes because, most people died before they happened, so it wasn't a big issue. But now, this 18-year-old girl will be facing amputations, kidney disease, by the time she's 35, 40. So if she has a baby, her vascular system will be affected and she won't be able to transport blood. So someone who's already got diabetes, reduced blood flow to the placenta again. Heart or respiratory disease, if they've got conditions, their heart doesn't work as well, they're not able to pump oxygen around the body as efficiently, so less oxygen goes to the baby as well, less growth. Malnutrition and anemia, we've spoken about those. We'll do more about iron and anemia when you get the pregnancy lectures. Infections, also deplete nutrition stores from mum as well, can cause other toxins to go into the body, can cause other problems. And then of course substance abuse, with cigarettes, drugs and alcohol all having problems as well. We've talked about this, the type of fetal growth, depending on when the restrictions occurred, the duration of it, the severity of it. So we've covered that, and we've covered this, and we're back with Barker's hypothesis about why he said what he did. So even though as a 40, 50-year-old you might make all the changes, you may not be able to undo it because it's all been genetically programmed. Fine. So, any questions about any of this? What you've got to think about is think of the stages. And I know it seems like a lot of material, and there is a bit of memorising that you do need there with the hormones and which ones are involved with which bits of the pregnancy, but the concept you really need to make sure you understand is maternal blood glucose levels and how it affects adiposity in the baby.